very large audience. We had something like 450 RSVPs. We're very eager to hear what you have to say. Your book is a bestseller. Even in pre-sales, it was on the bestseller list. So your message is breaking through. I'm going to ask you a question that I like to ask book authors and often gets missed in these kind of forums. So very simply, Mr. Gill, what's your book about?
The book actually is a personal and professional analysis of the world's largest health system, and it doesn't take an economic or sort of a business lens to the challenges it faces. It takes a psychological, emotional lens, and the premise is we spend in the United States, the world's biggest health market, we spend almost about 19% of our GDP, 20% of our GDP on health. We have doctors from all around the world who want to come to the States and train. So obviously we have an amazing training system for specialty medicine. We're really the center, the metropolis of health innovation around the world, molecular, medical devices, digital health, and so forth. So why is it that we have such poor outcomes? Why is it that we're dying 5 to 10 years earlier than most of the developed nation systems? Hong Kong spends a little more than 6% of their GDP on health, and they live 10 years longer than the average American. What's happening there? So the book doesn't go in and say, well, we need more technology, we need more information, we need better training, we need to spend more money. It has a basic, I think, assumed premise is we're doing all those things right. What we're not doing right is we're creating faster and faster a transactional health system that doesn't prioritize patients, and it doesn't prioritize the people who care for those patients, nurses, pharmacists, doctors, hospital staff, and so forth. It doesn't put them in the center of the ecosystem of care. And as a result of that, because we've made a transactional system, we have lost the center of care, which was a relationship between a healer and someone who wanted to be healed. And so if I were to put that in nice business terms, we have a fragmented, heavy friction system that clearly is not working. And other nations should take note. I think the United Kingdom, if people are from the UK listening in, I think you're feeling that now with the NHS. I think other nations, developed nations, are feeling that as well. As medicine becomes more specialized, we become more distant from the people who are assigned and desire to help us. And the people in charge of the system, in fact, aren't the people who desire to be healers, doctors. They're at essentially the beck and call of payers now. And so we have to take a look at what decisions are being made to get us healthier. And are we kicking the can down the road and embracing a sick care system?
It's something that many of us have talked about for a long time. I guess something I'm curious about is you have a very, very long and storied career spanning from combat medic to healthcare lobbyist to now leading you were in a private equity investment role. Now you're leading a global communications practice. You wrote a book 25 years ago.
That's true.
You've been a very, very active, prolific writer, both in print and now online. But I guess my next question is, why now? This problem, we could have had this conversation perhaps for all 25 of those years. So what is it now that inspired you to put this message together, and to what end?
Well, three things, Levi. That's a very, very important and personal question. And thank you for that. Three things. One, I don't think I could have written this book 20 years ago because I don't think the emotional state, the economic state of the United States was clear as it is right now about the problem. I don't think people were there. That's one. Two, the other issue is why now? I think I'm a different person than I was when I wrote that first book. First book, by the way, was also a success. People don't know I wrote a book 25 years ago called essentially Defining Your Brand in the Marketplace. And it was about health brands and the early stages of health brands, where I talked about head, heart, and gut, or the emotion about a health brand. And people said, no, health, emotion, what does emotion have to do with health? Now, that's 25 years ago. Today, I would say emotion has everything to do with health. If your life is on the line, it's not a cerebral issue. It's a very emotive moment. And I think that what we're seeing is doctors are not prepared necessarily for the tsunami of feelings and emotion people have when they engage the system. They're frightened, they're anxious, they're angry, they're hoping. All of that is emotive, and doctors are not really trained on people's emotions. And the third issue that I think is really clear to me is it's gotten to a point in the United States and in other places around the world, but thankfully, thank God, it's not played out that way, where um, a uh, a person who really is in need of help and health, Luigi, can go onto the streets of Manhattan, assassinate, murder a health executive, a health insurance executive, and it will be recognized as such a criminal act, murder. And at the same time, that person will be seen as a Robin Hood in society. What does that mean? And I'm not saying the majority of society, but enough people applauded his action and said, who else? That it sort of says that old movie, I'm fed up and I can't take it anymore. And that act of murder is that moment. I felt at that moment I had to get busy sort of bringing this all together for people to understand that we are at a critical moment. We're at a critical moment where we have to make a change. And my change in the book, and this is really important for innovators of the system, is not to destroy the system, heaven forbid. We can't sort of blow it up and say the healthcare system is closed for 6 months for renovations. That's not going to work. So what do we do tomorrow? Tomorrow to start making it better. And that's what I think kind of popped the book into the popular list, which was it wasn't yet another. Someone said to me, what I loved about your book is it's not a rant. It's not a rant at all. It's a thoughtful analysis of where we are, why, what we're going to do about it, and what you can do as a health professional, as a health innovator, as a health healer professional, as a patient, as someone in the administrative side of the business, as a policy side. Everybody can do something today, tomorrow, to get this on track. For those of you who are health innovators, I have some very important tips that you'll find throughout the book that will help you be much more effective. And Levi, this is my hat tip to you. I'm the one wearing the hat. You don't have a hat on today, but this is my hat tip to you in the mHealth community. You have really championed, since I had the privilege of meeting you 11 years ago, you've really championed conversation, not just about how to innovate, how to engineer, or how to navigate a regulatory system, but how to deal with the U.S. health culture. The health system here is a culture. Cultures can morph, they can shift. And I think particularly people in Israel or Europe, other places of the world, India, who might be listening in to this conversation, you have to be aware of how you help this culture adapt to your life-saving idea. And so the book goes through all of that in a very different form. It goes through it in terms of narrative, storytelling. I've had people tell me they've started the book and they were halfway through at midnight and they realized they were at that inflection point. Either I keep on reading till 3 a.m. or I get some sleep and continue the next day. It's not a novel, but it reads like a novel. What can I say? I wanted people to read the book, and thankfully they got it, or I got it
Good.
right, one or the other.
Yeah, yeah. We don't encourage people to read this instead of sleeping. We want our innovators to be fully charged. I would like to encourage anybody on the phone call, if you have questions, please put those into the thread. We'll try to do real-time Q&A from whatever you post. We'll consolidate some of your questions, but we really want to get to your questions. But there is a couple of interesting terminology items that I wanted to ask you to talk about, Gil. One is healthcare kinetics, which appears frequently throughout your book. And the other word that kept coming up again and again was friction. And friction can be the friend of the innovator, but it can also be an insurmountable barrier to the innovator. So maybe you could help clarify those sort of terms of art that you introduced throughout the
Yeah,
story.
first of all, very astute, very astute on your part. You really read the book, and I applaud that. By the way, if anybody's watching, this is what the book looks like. This is the softcover version, which I personally prefer. The publisher insisted on a hardcover. That seems that there's a group of people like hardcover. I like softcover for this book. But so let's start with health system kinetics. This health system has no prioritization. The system is the customer of the system today, not the patient. And so the real issue became that we don't center around a common goal. So if you really look at the system, the patient is actually often not the priority of the system. The system has people it reports to, you could say, or is accountable to, and I get it. I don't seek to change that. I say that in the book. But if you look at most of our private health insurance companies, they are publicly traded. And so the shareholders are a very important customer to them. Most of our health innovators have private equity firms that have backed them. They have limited partners. They report to the limited partners in many regards. They have to focus on return on investment. For the publicly traded product innovators, they've got shareholders. To the policymakers, they in theory have constituents, but they also have private interests. We're not going to change that, and my book doesn't suggest we change that. That's the great American system. And so I say, look, I'm for purpose and profit in harmony. But I am also for prioritization of what matters. And what you see is we have a system in the 1980s and 90s which was relatively simple to understand. You had doctors, you had payers, and you had patients for the most part. Medicare and Medicaid have existed since 1964, and were relatively well managed. They obviously we worry about the running out of money for it, but they were relatively well managed. And suddenly you have other layers that pop in. The rise of drug distributors of note, the rise of PBMs. All of these layers are coming in and doing something. And you have to say, okay, what is the value of each of those layers? There's countless layers. Each of those layers as it pertains to someone's health and their outcome, or prevention of disease, or healing, or outcome. What's their value? And so if you say, you know, something, health system kinetics means something relates to something. What's at the center of that circle should be people. Why people matter? Patients. We're always people. We're sometimes patients. And by the way, I've never met anyone that got out of life alive. And so that means at some point, we're all going to join the crowd of patients, hopefully later rather than sooner. But in many cases, we have some populations that are driving to the sooner as patients rather than the later. We can talk about that perhaps later on. But at the center of this are people who need healing. The system should center around, okay, what's the next most important thing to getting people healthy? Well, it's probably health professionals. They need to be prioritized also. When I speak to health professionals, and many were interviewed for this book and appear in the book, I might add that John White, the CEO of the American Medical Association, added his personal endorsement to the book. I talk about something very simple in health system kinetics and prioritization. Physicians have lost the authority of caring for patients. They can't say, oh my goodness, I need to do an MRI on this patient. They now need to go get prior authorization. Okay, that's fine. But who's giving them the prior authorization? An administrator who knows nothing about the patient. They're saying, well, did you try physical therapy first? Do 6 weeks of physical therapy. The doctor is saying, hey, I've got a patient with a torn rotator cuff. Physical therapy is not going to repair the rotator cuff, but I need an MRI to determine how badly is it teared. Try physical therapy first. Well, what does that say about the physician's authority over the care of the patient? So if we look at health system kinetics, we don't have the kinetics or the organization of that kinetics straight. What happens first and foremost is who gets the return on investment is at the center of the circle. And then it builds out. At the end of the circles, guess what? You and me. And so we've got to really reorder the circle to get to a better place economically for this nation and certainly for outcomes. And by the way, and certainly for the value of health innovation. Because right after physicians, if we look at what matters, health innovation saves lives. No ifs, ands, or buts. The drugs that I helped introduce in the 1990s, cholesterol drugs, drugs for hypertension, ACE inhibitors, statins, and so forth, no question about it, they save lives from people who would die from heart disease. And so when I look at this and I say, what's next? Well, what's next is ability to pay for it. We've got to be able to pay for it. That's the policymakers and health insurance companies. But when I look at what we've got right now, clearly the patient is not in the center of our attention circle. They're peripheral. And that's why I often say the system is the customer of the system. We're just there for the ride. Now, I'll give you a case in point that I believe so strongly about. If we truly cared about keeping people healthy, we would invest in a small amount of money, but a meaningful return on investment in preventive care. And that is as simple as teaching young children about taking care of your health. It's about investing in healthy school lunches and for in areas where there is not access to nutritious foods, maybe a healthy breakfast to start the day. And we would return PE as part of the budget, especially in an age of computerization where kids are on either their iPhones, their laptops, or their Game Boys or whatever. We would recognize that instead of running around and playing, they're running around in place, maybe, but they're playing. They're playing all sorts of video games, which is fine, but not in the absence of physical activity. We don't invest in that. And so we were wondering why in this country we've got 90 million Americans who are in the category of diabetes, pre-diabetes, type 2 diabetes, type 1 diabetes. Well, we are harvesting a nation of diabetics because we don't invest in the preventive education and care. And the book goes through that through narrative stories of doctors and people who are saying how they got where they are. And it's connected that way. I will say one thing, if we prioritized in health system kinetics doctors, why is it that 51% of our physicians are claiming to be burnt out, and close to 60% now of our nurses don't want to be nurses? It's a privilege to be a doctor or a nurse or a sort of a nurse technician, but we don't create the conditions that allow them to live well and to have time to care for patients. A story in the book is about my father-in-law's last 12 days of life. Great physician. He was a great physician. And a nurse asked me a question, and I said, that's in his EMR, his electronic medical record. And she said, and I quote, I don't have time to read patients' electronic medical records. Well, what's good is creating better electronic medical records if you don't have time to read the records. If you're on a 12-hour shift with 9 patients for 2 days in a row, then you have one day off, then you're on another floor. There's no continuity of care. If we had continuity of care, which is proven to produce better results, we would prioritize that in the system, in the relationship between the healer and the patient. So that's my answer to your question, Levi, of health system kinetics. Friction is what I just talked about. If we don't create time for people to be the best they can be, we're creating unnecessary friction, obstacles in the system. If you're inventing an idea that needs a lot of training, it's a great idea. It will save lives. You can put it on your iWatch, whatever the case might be, your Apple Watch, whatever the case might be, but you need to go through a 20-hour training course to be certified to use it, or it needs to be updated, or you're concerned about the cybersecurity of the device. We're creating needless friction that's going to stop your innovation from being embedded into the system of care. So you have to think of that. And guess what? No matter how great an idea is, if a doctor says, oh my God, now I got to learn this, enough. Friction is when you go see your doctor, as I do, I observe them. I have 12 minutes with my primary care physician, who I like as a person. He's attentive on the on essentially my link, my EMR, my online EMR, and he rarely has had eye contact with me. I sort of clock the amount of times he looks at me in a 12-hour. Now I'm not ugly, but he's looking at the laptop, typing in answers. He's married to his laptop. I don't know if you remember what I look like. I know his profile from watching him, but think about that. I have a relationship with a primary care physician who barely looks at my eyes. So they're focused not on building a relationship with their patient, they're focused on checking the boxes of the system. That's why the system is the customer of the system. That's friction.
Hmm. So we have a couple of innovators who are asking, where does the rubber meet the road? There's one individual, Moshe, he wants to know, maybe the system is designed and encourages fragmentation. And he's trying to defragment, and he's wondering how to address that as a rather small player in the larger landscape. Zena wants to know, how do we transition? Should we be proactive in transitioning towards patient-centered outcomes, that sort of thing? Again, keeping in mind that a Series A startup is not necessarily wielding the same influence as United Health Group, et cetera.
Well, first of all, again, I want to compliment you and the mHealth Israel community, because what you've done is the community actually at some point, maybe you'll facilitate this, Levi, is sort of principles of making a contribution, of providing value through life-saving innovation, which is what your community does so well. And I thank you, and I thank everybody from mHealth Israel who's participating today. Moshe, first of all, thank you for that question. And don't worry about the size of your enterprise, whether you're, one person or 30 people working tirelessly to make a difference in the world. What you do want to do, though, is say to yourself really clearly, for whatever you're doing, for it to work, how many steps are necessary for it to integrate into the system. That's one aspect you have to take a look at. If there are many, many steps, think about this. We live in a one-click world. That's like minimal friction. So when you go onto, for those of you who are familiar with Amazon, and by the way, my book is available on Amazon. They sell 70% of all books. So if you looking at the book, for instance, and you click on it, there's a button that Amazon has, which is buy now. All right. And the reality is that's one click. I look at the book, buy now, and it sends it right to my home. Now, if you think about that, that's kind of frictionless. If it's like, now go to the page and fill in your information. Now go and fill in your credit card information. Now check your information. Now click no buy, purchase. That's a multiple step thing. It's frustrating. How many times really, honestly, have people dropped out of buying something because it's like, I'm tired of another click, another click. You have to look at your innovation in terms of how many clicks to its use. Now, if you're looking at a molecule, you have to look at it as well. Is it included in guidelines? Can you start to work on discussing updates of guidelines? Is it available, and will it be on formulary? All those are hassle factors, friction factors. So if you're not on formulary, but you're an amazing medicine, and you hope that doctors prescribe, and they do prescribe, here's an often reality you face. They'll get the value of the medicine. They'll get the value of the medicine for their patients. They'll write about the medicine on their prescription pad. The patient will go to the pharmacist. The pharmacist will look it up and say to the patient, not on your formulary. They'll call the doctor and say, "What do you want to do? Do you want to appeal it, or do you want to give an alternative therapy?" At that point, the doctor may say, "I want to appeal it." No, I'll call. They may do that three, four times. When they get pushback, denied, 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 friction, friction, friction,
Mm.
they're no longer a fan of what you're doing. And so that's why thinking through to the last step about how will the doctor be able to do this and support the innovation with less friction is the responsibility of the innovator, not the system, not the system. So that's the aspect of thinking through as an innovator, how much friction to save a life. Doctors, even if they think it's going to save a life, if it's a lot of friction, I guess we're goners. Okay, that's that's Moshe's question. Uh,
Phil, I want to get you a t-shirt. It's a circle. It says friction in the middle and a big red line going
Oh,
through the
I'm with
middle.
you. I'm with you. I'd wear that t-shirt when it comes to saving people's lives. Zena's question is a very interesting question. I think her question is, hey, I'm one person. What can I do? Right? Well, um, I'm also one person, Zena. Um, I'm observant in looking at the system. If when you read the book and some of the stories, you can see I'm passionate, as my colleagues here at Fin Partners are, passionate about championing innovation to sustain and save people's lives. Passionate. And one of our values here is make a difference. And so this call in itself is my way of supporting you, Zena, and others to join me in raising our voices to champion health innovation that can sustain lives and not just your own enterprise. I mean, I'm fortunate to work with amazing colleagues where we are working together around the world, whether it's our specific client or not, to help people succeed. And I think that when you join communities that are dedicated to helping people succeed, you've got a better shot at it. I think that don't look at yourself in an island if you're on this call. There are tens of other people on this call who think like you, who want to join you. So you're not alone. Reach out to me or Levi or anybody for assistance. We're here to help. The other aspect is the book actually gives very concrete suggestions. And that's what people loved about the book. The last two chapters are not woe is me summaries. They're okay, let's change this. And so I think part of what you do to change this is is to begin to actually talk about talk with patients who could use what you're doing and understand their needs. Build a community of people who understand the science, understand the process, and can help. I think that's very, very important to the success of your efforts. No doubt about that.
Uh, that's for sure. So why don't we just give a couple bullets from those last two chapters, right? What is the takeaway, the marching orders, the call to
I don't want to give
action?
I don't want to give away the it's like the movie, like
Yeah.
spoiler alert. But I will um with your blessing. And by the way, I just want everybody to know that in the book, I go through people who are precious to me. There's a few pages, people and organizations that are precious to me. And as I go through mentors, colleagues, and leaders, there, there is Levi Shapiro. And so I'm very, very, very grateful to that. I'm very grateful to Levi and what he's doing, and this community, of course. Levi, I think that I've learned a lot through you and your advocacy for health innovators. So thank you for that. But I will read a very brief point about the shift of the American health system from the introduction. And it's a small little piece of just three short paragraphs that I think tell the emotive sense of this book. And let me just read this. I'm talking about the challenges that we face. I first grasped that truth not as a soldier or CEO, but as a child. My uncle had just returned from the army, and our family gathered to celebrate. Driving us home, he steered through a green light when another car ran a red and slammed into us broadside. I was wedged in the front seat between my uncle and my grandmother, my grandfather sitting in the back. In those days, before seatbelts, the force of the crash hurled us forward. I remember sirens, ambulances, and fire trucks. I remember my grandparents on gurneys in the ER, doctors and nurses rushing forward to care for them. What I do not remember is paperwork, insurance cards, or bureaucracy. Healers were fully engaged, urgent, and present. That was the 1960s. The contrast with today is unavoidable. Too often, passions are buried under paperwork, metrics, and administrative demands. The system prizes compliance over compassion and process over purpose. Have we lost sight of what matters most? The instinct to heal those who need healing? Let me repeat the last few words. The instinct to heal those who need healing. Every time a payer has to think about a prior authorization or says no without information about why, or engages to seek to learn and understand more. Every time they do that, think of the drain and strain on your personal life. Think of the drain and strain on the physician. Back to health system kinetics, the two relationships that actually matter at the center of this little business bubble. I have doctors who I have in the book who shared with me their names, who quit medicine, chairs of departments. They told me, I love treating patients. I can't stand the system. So when we take a look at friction, we have to say to ourselves, boy, are we creating a system where some of the best and most passionate doctors say, I opt out. I have two doctors I mentioned in the book, both high-tier orthopedic surgeons doing workmen's comp evaluations now instead of
Hmm.
doing surgery. It's just easier. They don't have to get up at 4 in the morning. They do a few hours a day and make a great salary. Is that really what we want in this country? I have stories of patients who shared with me they preferred to go to palliative care and die because they couldn't stand battling the system any longer. That's an extent of friction that is unacceptable. As an innovator, our job is not to add to the friction. Our job is actually to alleviate suffering or accelerate healing, one way or another. Don't add to the friction. Seek to help. Seek to help healers, seek to help patients. So the book has that emotive type feel to it and deals with real life situations that people felt very drawn to.
So, also in the book, there's a number of experiences, some extremely poignant and personal. I don't want to make you uncomfortable, but if it's okay, I want to talk about some of those experiences you write about.
Sure, sure.
Uh, Not everybody in the webinar may know that you have a daughter with a rare disease, and you, among all your many other activities, are also a caregiver. And there's been all sorts of unfortunate and avoidable difficulties throughout that journey. For example, misdiagnoses, unnecessary expenses, truly unnecessary procedures, sometimes individual arrogance. I recall the section where
Yeah,
a physician told you, who are you going to believe,
yeah.
the
We
patient
were,
or me?
yeah. Yeah,
And
that's a really good story, Levy. Thank you for that one because that stays with me. And as a health communicator, I I always sort of carry that story, sort of not in the back of my head, front and center, that we're communicating on the behalf of people. Companies that have innovation have to communicate on the behalf of the communities they serve. It's not about the product. That's a feature. It's really about what we can do to help with that product. And that was a case of my daughter was heading toward needing a feeding tube. Most young people at that stage begin to opt out for palliative care.
Mm.
um, usually about 29 years old. My daughter's older than that. And many of them just say, I don't want to do this anymore. They're not cognitively impaired, they're medically impaired. And I read stories that frighten me when I read about a young person who says, I can't do this I don't want to live like this. So, you know, I'm in the game. My wife is in the game. And this was a case of a famous robotic surgeon. I won't mention the name. By the way, if I diss a physician, I don't mention their name. If I applaud a physician, I do mention their name. So in this case, we have, because it's a very complex disease, we actually have the services of a patient advocate who knows this disease cold better than I do. And she
I
counseled
want
us.
to push on that for a second because
Yeah.
you probably have more relationships in the elite levels of the American health system,
Yeah, and I
maybe.
acknowledge in the book I'm privileged. I acknowledge in the book I'm
And
privileged.
in spite of all that, you opted, and your wife, who's also a healthcare professional, opted to use the services of a patient advocate.
Yeah, by the way, I'm a big fan of patients and
Uh,
patients who have cancer or other serious illnesses often know more about their illness than their doctors or doctors. And that's
yeah.
really critical. In this case, my wife, who was on the phone, I'm in the examination room with my daughter. My wife says, um, to the story you said, well, our patient advocate advises the doctor cuts her off and says what you said, who are you going to believe, a patient or me? Well, the patient, the other patient, my daughter, was sitting to my right. That's like saying, I don't believe you. Like, I don't take your experience or truth into account. Well, we politely wrapped up the visit. My daughter was in tears, um, not because of how she was treated, but what the ramifications of that doctor's advice meant. There was one other surgeon, it's a very complex surgery, dangerous surgery. One other surgeon we consulted with on the West Coast. We did a telehealth visit. He looked through the data. He said, I have a 90%, I'm confident I have a 90% chance of success. It's such a complicated surgery. Two surgical teams are available. One is a gastrointestinal surgery team. The second backup team is vascular. If they cut the artery, they jump in. They toss the GI team aside and they jump in. Got to the hospital on the West Coast. Doctor greeted us, took the nurses and doctor sort of took our daughter aside, and my wife and I quietly went to wait in the hospital's cafeteria. That's the meeting ground of stereo, sort of like wide eyes. And my wife's phone rings after a few hours, and uh, excuse me, the doctor says, Eleanor, it's Danny Shawad, the doctor. He just calls himself Danny. He says, where are you? Great surgery. Everything's great. Where are you guys? I said, cafeteria. He comes down immediately, right from surgery, still wearing his surgery scrubs, with photographs of the surgery, talking to us about what he did, how it was a success, so forth. And, our daughter will be in the hospital for a few days, but he really thinks it's going to have a great outcome. And he was right, by the way. Then he did something at the table very unusual. I cite in the book. He takes out a business card and he flips it over. He writes down his cell phone number. He says, this is my personal cell phone number. You're probably going to have questions. Call me at any time. The difference between one same surgery, two different doctors, two polar experiences. Why is that? Why is that? Why can't doctors recognize that on the other side of the room, when they're speaking to someone, are people who are hopeful and scared out of their minds that their kid may not make it? Why is it that one doctor has to be who you're going to believe, and another doctor is going to say, I believe you. I'm there for you. And by the way, he checks in with us, Danny Shawat. Is it going well? What happened was the artery, the ligament of this of our in this disease wraps itself around arteries at times and squeezes them shut. So the blood supply to the gastrointestinal system was closed off. She couldn't eat. That's why they have feeding tubes, just to bypass the system. He essentially resutured the ligament around the artery. That's the complexity of this. And so Why is it, though, knowing this, that these physicians can't be considerate of the patient because they've become so specialized that they no longer see the person who sits in front of them. They see a rotator cuff, they see a kneecap, they see a colon. And I talk about that in the book, by the way, that I have gastroenterologists who no longer are GIs. They tell me I only treat upper esophageal disease or I
Mm.
only treat colon. Imagine that. And so as medicine becomes more hyper innovative and specialized, suddenly doctors are trained not on treating people, they're treating a colon or a ligament or shoulder. And so we have to be careful that we select doctors. I do talk about that, not just on the basis of their IQ, but their EQ. At a time where large language models and Gen AI can help us remember biochemistry, maybe we need to prioritize, along with the IQ, essentially a desire to want to be a healer.
Mm. There were times when you were relaying your experience as a caregiver, and I could hear your voice crack. I could sort of feel the emotion and how personal it is.
I will
Uh,
say, by the way, my wife and I, because we were very fortunate, we helped another family that didn't have that quality health insurance. They needed another surgery similar to what my daughter had, another surgery, and we provided support for them to access this doctor. Another doctor, she needed a spinal surgery, same reason, ligament attached itself to the spine. Young person didn't have that health insurance. They only take, essentially premier health insurance. We essentially worked on closing the gap. Um, the fact that we're in a system, one of the richest nations in the world, and young people who are wonderful and are struggling can't get the care they need when the care exists is part of the friction. And so I think that for us as a great communication organization, we never forget that it is about why do we do this? It is certainly to champion health innovation around the world, and it's to champion it so it can sustain and save lives. And I think that's a unique feature here. And I tried to bring that out in the book. We've got to work together to help people live healthier lives.
so people are asking how they can reach you. I'll put your email in the comments.
Absolutely. Please.
Okay.
Please.
People are saying in their geography, the book's not yet on Amazon. I read it on Kindle in Japan. Um, Gil likes his soft paperback. I like a nice Kindle. I can read in bed while my wife's asleep. Um, but I do want to push on that EQ comment because I do think that's something you bring that our system deprioritizes. And I want to ask you all the many roles that you've had. What are some lessons that you pulled out? One from the outside might say, hey, a guy who worked in private equity is talking about EQ and patient centered. You are also an industry lobbyist who is usually not, somewhere between congressman and
I
serial
was.
killer in
Well,
terms
not
of
but
popularity.
certainly working with the House Energy and Commerce Health Subcommittee and Senate Health, Education, Labor, and Pensions, um, and being a state lobbyist in the state of New Jersey, which is the medicine chest of the nation then.
Right.
But I understand that that looks like a bit of a dichotomy. How can I go from a lobbyist to advocate? It's because I have those experiences and I understand what drives those people. Having been a portfolio CEO of one of the larger private equity groups in the United States, then $4 billion in active management, today $10 billion. I understand exactly the dialogue that goes on. I get it. I don't. I don't seek to change it. I The book sort of says it's not going to change. Don't change it. You got to work through it and with it to succeed. And that's the unique part of the book, which is it's not talking about a new system or the destruction of the system. It's talking about rebuilding a system that remembers our humanity. Just because you're involved in profit, and by the way, profit and purpose are not at odds. They should be in harmony. You cannot have a sustainable health system unless it can survive economically. So they're not at odds with each other. We've got to come to grips with that. But here's what could happen. A doctor or a nurse can be given the bandwidth to not lose their patients. A doctor or nurse can be given the resources to support the people they're charged with helping. A product innovator can understand that when they built a relationship with a community over a disease state, when their product goes generic, it doesn't mean all of a sudden saying, I'm no longer interested in that patient. I can't make money from them, so I'm not going to do patient activities. It's we made a lot of money from this product with that patient community. Some of that investment has to go to new products, and some of that investment has to go to sustaining our relationship with that community because probably we're going to be back in that therapeutic category. So rather than turn the tap shut, we have to keep it open somehow and support that community reasonably. All that is understanding that people matter. People matter. And so when a company said, hey, we made X billion a year on a product, but now it's generic. So our attention is elsewhere. Sorry. The company has to say, hey, we made a lot of money on this product. This patient community relied on us for their public awareness and education. And as an outcome of that, we too benefited. We have to continue some level of support here. It involves leaders being leaders of the health system as opposed to leaders of the balance sheet. I state very clearly and often, I think having been in private equity and learned well how to read a balance sheet, no, without seeing the entire balance sheet, I can almost tell you the profitability EBITDA of the company. And I also believe that I'm part of a community here at Fin Partners that has another balance sheet, which is the balance sheet of people. And we understand that people matter. So Peter Finn has created a business here that thrives, it's sustainable and stable. And guess what? We have a profit balance sheet and a people balance sheet. They both matter. And I would say that our industry would be well served from a reputation standpoint if it started to enforce that on its own terms. And I'll give a great example that I think I touch on in the book. When Roy Vagelos of Merck donated ivermectin, which is you better known as HeartGuard or something
Oh,
like that for
yeah.
pets, but he donated ivermectin to combat river blindness. And river blindness today is almost eradicated in the world thanks to that move. It was applauded. It was on the front page of the New York Times Magazine. It was a historic moment. And Merck continued to make billions on ivermectin in the animal health market. But he did not turn his back on needs. I think our industry can look at that and say, if we want to actually shine the reputation that we've enjoyed or had enjoyed for decades before, then we have to lean into it and make that purposeful.
Good. We're coming up on the final stretch. I want to do a few lightning round questions. First, I want to address a question from Marone. He's asking if you can share lessons for global innovators who don't live in the US. What is it that they should take away from your book?
Well, I think the biggest aspect is that people have feelings to some
Right.
extent, and when if no matter where you live, depending on what market you seek to serve. So, if you're living, for instance, in Israel and your market is Israel, then I think the same thing applies. Israel is a very developed health system, one of the most developed in the world, and actually one of the most technologically sophisticated in the world, particularly as it deals with health information. There's a number of systems there. I think Clalit and Ron Balasir, who's their chief innovation officer there, is someone to learn from. And certainly I've been privileged to be in conversation with him there. But when we take a look at it, we have to take a look at the quality of information that you're using. And I would say that all around the world. AI is not the answer. It is a tool, just like this laptop I'm speaking to you through is a tool. AI is a tool. The information that it's curating is either accurate or inaccurate. As it wanders from inaccuracies, of course, the answers you get are inaccurate. It's sort of forms of misinformation. So one aspect you can be is understand that driving innovation, whether it be information, whether it be engineering, are people. So those people can't lose sight of who they're serving. That's one very simple aspect. Two, you can do an assessment of saying how one clickable is my idea, in essence. You may love your idea, but for the user to deploy it, it involves a lot of sort of like resources, people, training, money. If that's the case, you've got to sort of sit back. I'm not saying it's not a great idea. I'm just saying you got to make it easier for the user to deploy in order to be hyper successful on their behalf and your own behalf. That's another one. The other aspect is don't rant or rail against the system. Understand the system and understand where you fit in the system. And that's important. If you think you're going to change the system, that's a big hill to climb. Not impossible. Nothing's impossible, but it's a big hill to climb. Think that through. And then also recognize no matter where you are in the world, obviously profit is important. Even if you're a not-for-profit, by the way, you need money to operate your not-for-profit. Doesn't mean you need to show a profit at the end of the year, but you certainly need resources. But profit and purpose go hand in hand. What is the purpose for your enterprise's existence? Be clear about that and celebrate that. Those are some what I'll call mindset behaviors you've got to prioritize.
Gil, I want to create a scenario. This will be our final question. People in the audience may not be aware that you are on a number of very prestigious board of directors. The Gallian, the Prix Gallian, which the Nobel Prize for Corporate Pharma R&D, the Marfan Foundation. You're a regional head of the American Heart Association. So I want to use the analogy of you're in a board meeting, and the board is very diverse. There's a hospital CEO, there is an insurance exec, there are all sorts of stakeholders, right? Diverse stakeholders. Even a patient advocate is in that room. And you have a very generous donor, wonderful donor who says, hey, I've got $10 million. I want you as a group to do the most good. That's it. And 30 minutes later, the group doesn't know what to do. And they say, Gil, you're the professional communicator. What do you tell that donor with his $10 million, right? And that's not enough to build a new wing at the local hospital. So in that scenario, it kind of distills your whole book into actions. What would you do?
That's a really great question for 1 minute. But but you know, depending on the state of the hospital, first of all, and by that I mean I don't know the status of the nursing staff, or actually the people who actually support patient care in the middle of the night. There are people who change sheets and bring ice and little glasses to people who can't eat and stuff like that. Um, but it ranges, Levy. Sometimes it's the simplest things that have the big sort of butterfly effect. So it's the simplest things, such as, how do you support the sort of the nurse downtime room, in a way that lets them know that they're valued. Nursing, for instance, is the backbone of care in a hospital system, and yet it's sometimes underappreciated. Here in New York City, we're facing a nursing strike, for instance, over pay increases. And one of the statements they made is, why is it that a hospital administrator makes a large seven-figure salary, and we have to live an hour and a half away because we don't have enough money for New York City rents. So it varies from city to city and need to need. You need inspired nurses. That's a given. You need young residents and interns who are not working 80-hour weeks because that's what the previous generation did. So I would say I would first and foremost look in the hospital system of how do we create an environment for care providing that supports those people first and foremost. And that could be training, it could be grants, it could be everything from sort of access to a coffee machine for all I know. It's not always health innovation. Sometimes it's actually investing in the most potent resource that a hospital system has, its people. So I would probably say I would probably look at the people needs first and foremost. Number one. Number two, I would look to some extent at some of the essential patient needs, particularly pediatric patients. It's amazing how small investments in inpatient pediatric care have the biggest emotional, psychological impact, not just on the children who are needing care, but on their families. So I think just on offhand for that question, that's where I would go. Invest in the healers, invest in the youngest, most vulnerable patients as my first priorities.
Very nice. You gave us quite a bit to think about. We will have all of this on video. We'll post that. What's the name of the book, Gil?
Levy, thank you. It's called Healing the Sick Care System, Why People Matter. I always say we're always people, we're sometimes patients, but people matter. Whether you're a healer, whether you're a patient, whether you're a caregiver, whether you're a payer or a product innovator or a policymaker, everyone matters. It's time we appreciate each other and remember our humanity.
Well, thank you everybody for joining. Thank you so much, Gil, for your support of all of the innovator community, for this book, for your message, for your energy. And let's all undertake to wear our no friction t-shirts the next
I'm
time we
looking
see each
forward to
other.
seeing those, Levy. We're going to hold you to that. And
Okay.
again, thank you to you, Levy, for supporting and organizing this conversation, to everybody who joined us and everybody who will listen to this exchange. Thank you for your leadership.
Okay. Thank you so much, everybody.